Good morning, everyone. Thank you, Dr. Vinita, for having me here in this course on biometry. So I will be talking about biometry in special situation. I don't have any financial interest. The slides are not moving. The slides are not moving. Yeah, thank you. So I would be primarily talking about longer axial length of and shorter axial length, sulcus placement of IOL, silicone filled eyes, and post VR surgery eyes. So why are we considering this long and short eyes? Because the effective lens position, which is the most very important component of IOL power calculation, it is assumed to be similar for all the types of eye. Suppose we have a longer eye, that doesn't mean that there would be effective lens position which will be always the similar. Because in longer eyes, anterior chamber depth might be great, might be deeper, but this won't be always there. So accurate measurement of effective lens position is very, very important. And then of course we need to be sure about the IOL availabilities. So effective lens position predictability can be calculated by various parameters like axial length, keratometry, horizontal white to white, refraction postoperative, anterior chamber depth, length thickness, and of course the age. So what is the predictive IOL position? So it is the posterior part of the cornea and then anterior surface of the IOL. So it might vary in different subset of patients and also in patients in which the IOL is not implanted inside the bag. So we need to have personalized A constant, as Dr. Vinita has just now emphasized. We need to have 4th generation formula which are more accurate because there are 7 input variables involved in these formulas. So for extremely long eyes, whenever we are doing optical biometry, it is important to visualize the fovea. So swept source biometers, they can help to locate fovea in a better way and therefore are better for IOL power calculation. If we are unable to do on optical biometer due to some of the other reason like mature cataracts or dense PSCs, then immersion is way to go. Now, because in myopic eyes or the longer axial length, we have low scleral rigidity, therefore contact biometry should not be done in these patients. We also need to aim for a slight amount of myopia of -0.5 or -0.75 in these eyes. And if we have an axial length of more than 27 millimeter, then contact biometry can produce a big amount of errors. So we should be careful about these. So whenever we are talking about myopic eyes, now this was a very good study in which they found that high myopia is associated with variable biometric measurements, and that can be due to variety of problems. Now, we don't have isolated myopia only, we have myopia in other ocular disorders like retinopathy of prematurity, exudative vitreoretinopathies, Marfan's, Stickler's. Now, the thing is that in ROP group, they show significantly shorter axial length despite being myopic. Similarly, in Marfan's group, there is significantly flatter corneas despite being myopics. And same as with the Stickler syndromes group, they have longer axial length compared with inherited myopias. So we need to keep these points in mind while we are calculating the IOL power. So this was another study, and they found that Haggis and Barrett Universal 2 formula have a better success rate in predicting IOL powers in high myopic eyes with longer axial length. So Barrett Universal 2 or Haggis with optimized A constant is way to go. In these myopic eyes, we need to adjust the optical biometry axial length, which is suggested as a Van and Cox modification in JCRS. But I think Barrett Universal 2 is the formula which is quite commonly used these days and gives a very good results to all of us. And because it is also available free online, therefore we can all use this particular formula. drhill.com or ascrs.com is the website where you can go and check with these formulas. Now coming to extremely short eyes, because these eyes are extremely unforgiving, therefore IOL prediction should be very, very particular, particular in these eyes. So small errors in axial length measurement, they have disproportionately larger effect. So change of axial length, say from 20 to 19, will change the IOL power by 5 diopters. So small shift in effective lens position also causes big refractive surprise because the lens is thicker and it is closer to fovea. Hofer Q is supposed to be more accurate if we are using ultrasonic biometry, but fourth generation formulas, they are always preferred in such eyes. Now coming to sulcus placement of IOL, here we need to follow the formula of 9S. So suppose we have axial length between 17 to 28 diopters, we need to decrease by 1 whenever we are planning to place the IOL in sulcus. Suppose you have a posterior capsular rent and now you are placing the IOL in sulcus, you need to reduce by 1. But if the patient is having IOL power of less than 18 diopters, then you decrease the IOL power by 0.5 if you are planning a sulcus placement of IOL. But if you have the power is more than 28 diopters, you need to decrease the power by 1.5. So if optical biometers are not available like in hard cataract or mature cataracts and dense PSC, you can do immersion A scan, even if you can also increase the gain to get those readings. Now coming to post-vitrectomized eyes or silicone-filled eyes. Now because speed of sound is slower in oil than in vitreous, and therefore usage of standard sound velocity can give error up to an extent of 8 mm in these eyes, especially if it is silicone-filled. Therefore, ultrasonic axial length that overestimates the IOL power in silicone-filled eyes, and moreover, there are problems of multiple interfaces, there is sound attenuation, and there is low scleral rigidity also. So optical biometry should be done in these eyes, and it has been found to be 10 times more accurate than any other conventional method. So these silicone oil filled eyes or silicone oil dependent eyes, the problem arises when optical biometry is not available, and sometimes dense media due to advanced amount of cataract leads to fixation problem, and immersion with increased gain is the answer. Another important point is you should make the patient sit, because once the patient lies down, the silicone oil interface that changes, and that can cause variable readings of axial length. Now here, because the velocity inside the silicone oil is different, therefore we need to apply this factor if you are not doing it on some advanced 4th generation formula. So normally the sound velocity which we use in all the biometers is around 1550. But here, if the silicone oil of 5000 centipoise has been used, the velocity you need to feed in is 1133 or 1140. So what we do, we take a factor, like we use 1133 divided by what is the velocity which has been fed in the machine. So we get the A constant of 0.72, and that should be multiplied in the measured axial length to get the correct total axial length. Similarly, if silicone oil used has a 1000 centipoise of gravity, then you need to take the sound velocity of 980. So you will be dividing 980 oblique 1550, and that would be multiplied in the measured axial length to get the correct axial length. You need to aim for higher power of 2 to 3 diopters in these eyes which are silicone filled. So to summarize, I would say that optical biometer with swept source is the answer for best of your readings. But if it is not available or you are unable to perform, go for emulsion biometer, and then Barrett's formula online, Barrett's 2 is the good formula to use in all such eyes. Thank you so much for your